Stem Cell Transplant, Medical Division, Command Hospital, Lucknow. He'll be enlightening us about the unlocking new horizons in myeloma from monoclonal antibodies to bispecific agents. I welcome you, sir, for this session.
Thank you, ma'am. So, good evening, everybody. At the outset, I'd like to thank Dr. Avirti for giving me this opportunity, and also to Johnson & Johnson for sponsoring this session. So, most of the part of this discussion, I hope my slides are visible.
Yes, sir, your slides are visible. Please just make it full screen.
I'll do that. It's okay?
Yes, sir.
Thank you. Yep. So, we are going to talk about multiple myeloma and how the story of monoclonal antibodies and bispecific antibodies are unfolding. Monoclonal antibodies have been what we have been using for good about, I'll say, 6 to 7 years now in India, and we are well versed with. Bispecific antibodies, as far as myeloma is concerned, is something which at least I have not been able to use, but we have been talking quite a lot in the last 1 to 2 years. Now, it is available in India. Teclistamab is available in India. We are even having a international trial. An international trial is ongoing in India, which is evaluating the efficacy of two monoclonal antibody combination, Teclista with Teclita. So, in the time to come, perhaps we'll have more and more exposure to bispecific antibodies in myeloma, as well as in other hematological malignancy. It's going to be the talk of the town, because their responses and all are at times superseding even the transplants. And they're very effective with relatively a few known and easily manageable adverse events. So we'll go and talk about that. So total time is very less. Let us start it without wasting any further time. So I'll be talking about the introduction to a disease, diagnosis and management guidelines, particularly the NCCN ones, some of the trials, whatever I can cover. Then about there are subcutaneous formulations, and what are the options post monoclonal antibody therapy, basically the bispecific what we can use. So myeloma, as we know, is clonal disorders of plasma cells, and it is characterized by overproduction of ineffective monoclonal immunoglobulins, or what we call antibodies, which are ineffective, and there are lots of osteolytic bone lesions. The management of multiple myeloma, as it is said, that it is treatment is a marathon and not a sprint. We keep on treating it over periods of years, many years, and the longer the initial efforts were to just make it longer, the duration of the therapy, so that patient survives more and more. Now, with the neurotherapy and all, we are seeing more and more patients are getting cured of myeloma, rather what we call treatment-free remission. They are entering into, at least about 5 to 10% of our patients also presently are in treatment-free remission, around 10%, I'll say. So that's a good thing coming. Though at the same time, many of them, they just don't respond. They have refractory disease and they keep on worsening, and have very rapid deterioration of the disease. Anyway, so the current overall treatment paradigm, if we talk in myeloma, involves the patients who are transplant candidate. We put them on induction therapy, usually with a triplet for 4 to 6 months, sometimes 8 months. Then we take up the patient for transplants, followed by sometime consolidation therapy. Sometimes there may not be any consolidation therapy, particularly in those who are MRD negative post-transplants. And then we go for maintenance therapy. Usually we take maintenance as lenalidomide is our preferred maintenance thing, and the duration usually is around 2 years. And those who are non-transplant, there we go take the induction therapy, usually 10 to 12 cycles, not 6 to 8, or 4 to 6 or 4 to 8. And then we put the patient on maintenance after about 10 to 12 cycles. So that is overall things. If you talk about the daratumumab, the first monoclonal CD38 antibodies what we got in India. So it is first in class human IgG1 mAb that targets CD38. So demonstrates single agent activity. That is important, that at time it is one of those drugs which is authorized, which is I think as per the guidelines, it is recommended to be used as a single agent also in the relapsed refractory multiple myeloma setting. So that is an important thing to know. I will hurry up a little bit because the time is very limited. This is what I understand in this talk. So overall, for transplant candidate patients, the standard is usually we go with VRD or even sometimes DARA VRD or DARA RD, and then followed by ASCT, the transplant, and followed by length maintenance. For high risk, usually given an opportunity, we would like to go for DARA-based quadruplet like DARA VRD, DARA VTD kind of therapy, followed by transplant and then maintenance. Maintenance earlier was lenalidomide or in high risk len plus bortezomib or bortezomib alone. But these days in our practice, usually we go for daratumumab plus lenalidomide. I'll let you know. We'll talk about the evidence which is there behind using daratumumab and len as the maintenance in high risk cases. And non-transplant candidates, we can go with dara len dexa or just Bortil and Dexa and continue the therapy until there is progression of the disease. So if you go by the NCCN 2024 guidelines, it also says that, and for relapsed refractory patients, it says that if patient is PI refractory, then carfilzomib-based therapy or daratumumab-based therapy can be used. If patient is refractory, then again DARA or at times you can go for carfilzomib-based therapy. So these are the two readily available drugs with us, selinexor or elotuzumab or isatuximab, which are also very effective in these kind of refractory settings, are in general not available with us unless some of us are importing some of the drugs. So one evidence-based evidence I'd like to talk about today is this Perseus trial where DARA, Borti, Len, and Dex, DARA VRD, was used for multiple myeloma. So we see for transplant eligible newly diagnosed multiple myeloma to begin with VRD induction followed by ASCT or followed by ASCT, and then consolidation may be there with VRD, and subsequently the lenalidomide, len maintenance, has been considered the standard of care for most of the patients who are transplant eligible in our setting or most of the places all over the world. However, there was a need for the better therapy or novel therapy which can improve the outcomes. So Griffin study was done subsequently, and that shows we are talking about the monoclonal antibodies evidence to be used in the myeloma. So this phase 2 Griffin study demonstrated that DARA VRD induction followed by autologous stem cell transplant, then maybe consolidation, and then DARA len maintenance improved the depth of response, deepening of MRD negativity over time, and improved PFS over VRD alone, followed by transplant. Same, whatever standard of care was there. Then came the Cassiopeia trial, and in this phase 3 study, it was demonstrated that DARA VRD, DARA Borti, Thal, Dex, DARA VTD induction followed by autologous stem cell transplant, followed by 2 cycles of DARA VTD consolidation, and followed by DARA maintenance improved the progression-free survival versus VTD, Borti, Thal, Dexa induction followed by transplant, followed by VTD consolidation and observation in patient with transplant eligible newly diagnosed multiple myeloma. So this was one thing. Then finally came the Perseus trial, what we are going to talk about right now a little bit. This phase 3 study was designed to evaluate the DARA subcutaneous in combination with VRD. So the overall the quadruplet is DARA VRD. This induction followed by transplant, followed by DARA VRD consolidation, 2 more cycles, and followed by finally DARA len maintenance. And it was compared with the standard of care, what is VRD induction followed by transplant, followed by VRD consolidation and len maintenance in patients who are transplant eligible, newly diagnosed multiple myeloma. So this was the study design of Perseus trial. The key eligibility criteria were transplant eligible newly diagnosed multiple myeloma, eligible for high dose therapy and stem cell transplant, age was 18 to 70 years, and performance status 2 or less. So induction standard of care VRD, as we know, Borti 1.3 milligram per meter square, subcutaneously 14811 21-day cycle, and the len 25 milligram orally day 1 to 21, and the Dexa 40 milligram oral or IV day 1 to 4, and then day 9 to day 12. And it was compared with DARA VRD, where DARA was given 1800 milligram subcutaneously weekly for first 2 months or 2 cycles, then followed by every 2 weeklies from cycle 3 to 4. and it was followed by transplant, and then there was consolidation with VRD in VRD arm and DARA VRD in the intervention arm, where DARA was given 1800 milligrams subcutaneously every 2 weekly, same as the induction one. And then came the maintenance arm. So then come the maintenance phase, where the VRD people, the VRD patients, they received len 10 milligram orally from day 1 to 28 until it's progressive disease. And the patient in the DARA VRD received DARA 1800 milligram every week and len 10 milligram orally from day 1 to 28. If they were MRD positive, then they continued at 1 year. Then they continued DARA len until progressive disease. And if they were DARA, if they were MRD negative, then they continued DARA therapy only. Then they discontinued DARA therapy only. Len was continued over here also. So the primary endpoint was progression-free survival. So as far as the demographic and baseline characteristic was concerned, it is not very clear. There's some issue with the color, but the overall thing was it was well matched. Both arms were well matched. And if we look at the patient disposition, so almost 25% of the patient in the DARA arm and 50% of the patient in the standard of care VRD arm discontinued the therapy. If you look at the median duration of study treatment, which was 45.7 months for the in the DARA VRD group, and it was 42.2 months for the VRD group. Going ahead, the primary endpoint, which was progression-free survival (PFS). You can look at the Kaplan-Meier curve on the right side, the DARA VRD versus VRD. So it is definitely visually also we can comment on this, that the DARA VRD arm did better. If you look at the p-value, then it is less than 0.001. So at a median follow-up of 47.5 months, the disease progression or death occurred in 14% of the patient in DARA VRD group and 29% patient in the VRD group. So DARA VRD significantly improved PFS. So if you look at the pre-specified subgroups in this forest chart, you can see on the bottom, you can see right in the middle, that the DARA VRD was preferred in almost all the groups, almost all the subgroups, except those were equal to more than 65 years of age group, when number of patients were little less. It was in the middle. Otherwise, almost all subgroups, whether it is ISS disease stage 3, non-IgG multiple myeloma, cytogenetic risk, high risk cytogenetic risk is concerned, poor performance status is concerned, for each and everything, it was DARA VRD which was considered to be a better one. If you look at the CR rates, so CR rates or mode was almost 87.5% in DARA VRD in comparison to 70% in VRD. It is expected also. And again, if you look at the subgroup analysis of overall CR or mode kind of response, here also you can see in this forest chart right in the middle and towards the down, that DARA VRD in all the subgroup was better in comparison to VRD. So if you look at the MRD negative, it was much better in DARA VRD group. If you look at the late MRD, you can see that MRD increased with time in the DARA VRD group in comparison to the VRD group. So MRD negativity rate was improved to DARA VRD versus VRD across all clinically relevant subgroups, again as being shown in this forest plot. Adverse effects, though it is not that very clearly seen, but it was comparable. There is no major issue as such. Yes, of course, the infusion-related reaction is expected to be more in case of DARA VRD in comparison to the VRD alone. So if you look at the conclusion and the key takeaways, the DARA VRD induction, ASCT and DVRD consolidation followed by DR maintenance significantly improved PFS. That was the PFS benefit over there. Depth of the response was more as it was MRD negative. Safety profile is comparable, and place of therapy it was so important that these results supported DARA VRD and DR maintenance as a new standard of care for patients with therapy eligible newly diagnosed multiple myeloma, and based on this drug was approved. The another evidence is the final analysis of the phase 3 non-inferiority Columba study of subcut versus IV daratumumab. So here I'll just touch upon a few points. So here head-to-head DARA subcutaneous versus DARA IV was compared. DARA subcut, as we know, the standard dose is 1800 milligram and DARA IV 16 milligram per kg. So well matched two subgroups, and when the overall response rate was compared from, then we can see over here that it was around 41 to 37%, and the final analysis it was 44% in subcut versus 40% in IV subgroup. So the overall response rate, the ORR, and the depth of responses improved over time from primary analysis to the final efficacy and safety analysis in both treatment subgroups, but it was still little more in the subcutaneous group, so it was non-inferior in comparison to the IV ones. That if you talk about the concentration, the trough level, that was also acceptable and met the non-inferiority criteria. And PFS, as you can see, both are going head on head. Overall survival also head on head, not much of differences. Infusion-related reaction, yes, of course, it has to be more in the patients who were or in the group who received the IV comparison to the subcut. It was 13% versus 34%. So there was significantly low infusion-related reactions in subcutaneous group as expected. Rest of the side effects almost comparable. We are not expecting also anything much different, and it was almost comparable. Like you can see, grade 3 or more therapy emergent adverse events, DARA IV 52%, DARA SC 50%, so almost similar. So what are the possible? So we can see here now that in a high risk patient, we can easily go with quadruplet DARA VRD followed by consolidation if required, and followed by DARA lane maintenance. That is one thing which is doing slightly better than the standard VRD in these patients. And as far as subcut versus IV routes are concerned, subcut is non-inferior to IV, or maybe at times slightly better only. Now, what are the possible options for patients who have progressed from on monoclonal antibodies? So I'll just take about 5 minutes and finish up. This is the last part of the talk. So if you look at the NCCN guidelines, so it says that patients who have failed 4 lines of therapy, particularly including anti-CD38 antibodies, and 1 proteasome inhibitors and 1 immune modulators, then CAR T-cell therapy is one option, and the other options are bispecific antibodies, particularly to name is talquetamab and teclistamab. These two are these days available in India. Teclistamab is available formally after DGC approval, and talquetamab, some of the clinical trials are being done, particularly here in Lucknow in SGPGI, only it is going on right now. And other recommended, then those conventional bendamustine kind of therapy and other things can be given. Even selnixafor is one thing which can be given in patients who have failed to monoclonal antibodies, though usually it is not available with us. So you can see as that we keep on treating, the response rate and the depth of response or other thing keeps on decreasing. And finally, patients who are multi-drug refractory, the best option these days with us are either to go for CAR T-cell therapy or bispecific antibodies. So if you look at the different CAR T-cell therapies which are available with us these days, then the two most famous are teclistamab, which is BCMA CD3 bispecifics, and we also have another one called teclita. Teclistamab is one which is available right now, so we'll just talk a little bit about teclista in today's study. So it is a bispecific antibodies. It is the first approved BCMA CD3 bispecific antibodies. The disclaimer is that I am yet to use this drug, though I am very impressed, as I will discuss with you, with the data of this this drug as far as efficacy is concerned or the adverse event safety profile is concerned, and looking forward for getting this drug. We are in the process of procuring this drug. Once we get it, we'll definitely use, and maybe in the next meeting or so, I'd like to share my own data, how is the efficacy and the safety. But as far as the published clinical trials results are concerned, the overall response rate in this Majestic 1 trial, which was phase 1 or phase 2 trial was around 63%. This is 63% in this multi-refractory subpopulation of multiple myeloma who have even failed on monoclonal antibodies is quite a lot. So let us see this data. So the primary objective in this Majestic 1 or 2 data was that to evaluate the efficacy of teclistamab at the RP2D recommended phase 2 dose of 1.5 mg per kg and a step-up doses of 0.06 and 0.3 mg per kg. So the eligibility was that there should be miserable relapsed refractory multiple myeloma equal to more than 3 previous lines, including a PI, 1 IMiD, and 1 anti-CD38, and no prior anti-BCMA therapy. And endpoint was primary was overall response rate. So I'll go through quickly in here. There were phase 1 40 patient, 125 in the other one. If you look at these patients, the extramedullary plasmacytoma was in 17% of the patient. High risk cytogenetics was there in 25% of the patients. Prior lines of therapy, more or 4 prior lines of therapy were there in most of the patients. And autologous transplant was done in already 81% of the patient, and allogenic in 4.8% of the patients. Triple class exposed were 100% of the patient, and penta drug exposed were 70% of the patients. So very highly treated patients were there, relapsed refractory patients were there in this study, and overall response rate was 63%, which I'll say was quite a lot. And if you look at this various subgroups, we can see down below that from 0 to 100%, if you look, most of the subgroups, they had around 50%, little less or little more, around 50% response in both the arms. And the adverse events, if you look at, the most important thing to understand was that CRS was there. It is there with all monoclonal, all bispecific. If you see, the cytokine release syndrome is a common phenomena, though the grade 3 or 4 was seen in only one patient, but 1 or 2 was there in most of the patients, 72% of the patient. It is expected also. Apart from that, cytopenia is one thing which are prevalent, which is again expected in multi-refractory multiple myeloma whenever you are treating. And apart from that, there was very little bit of grade 1 and 2 effects, various GI side effects or infection and other things. So, if you look at specifically the CRS thing, so patients who required tocilizumab to be treated was around 1/3 of patients, around 36%, and many of them required low flow oxygen, corticosteroids, and vasopressor at times for managing hypotension. Time of onset of CRS was around 2 days, what is expected, and the duration, median duration was around 2 days, and 100% of them had resolution. If you want to decrease the CRS in this cohort of patients who are being treated with bispecific, the best way to go ahead is antihistaminics, antipyretics, and corticosteroids. And stepping up a dose is required, like you start with little less dose, maybe 0.3 milligram kind of thing, or even less, and then you go up to 1.5 milligram per kg dose. Once it happens, then the tocilizumab IL-6, what we use in tons during COVID, is the treatment of choice, or is the most important weapon in our armory. Apart from that, corticosteroids can be used for milder cases, particularly the dexamethasone or methylprednisolone. And if patient is having hypotension, better to use vasopressin, noradrenaline, to be in particular, and nasal cannula to give some low dose oxygen. And dose interruption can be required sometimes, most of the time it is not required. If you talk about ICANS or neurotoxicity, what is there? It is very less. Most of the bispecific have less. ICANS is mainly seen in CAR T cell therapy, what I understand. But in bispecific also at times it can be seen, and here also in 3% of the patients, ICANS was there. ICANS is usually a frightening thing where patient gets into start having altered sensoriums, and you find it very frightening at times. But yes, that is also most of the time very well can easily be managed in an experienced hands. So overall, the study showed that before that infection. So 76% of the patient experienced infection. The most common infection was a URTI, which is in general not very difficult to treat. And 44% patient had experienced grade 3 and 4 infection. In our setup, particularly in the developing countries, as we see, our patient most of the time they die because of the infections only. It is a very important thing to remember that almost half of the patient they experience grade 3 or 4 infections with teclistamab. So if you are using it, better to be prepared with where are you keeping the patient, where are you treating, either they should be treated at, on OPD patients at home, or if you're treating them in the hospital, please think about the kind of rooms which will be provided to the patients where you will be treating and all. 83% of patients received antiviral prophylaxis, 5% antifungal, and 11% received prophylactic immunoglobulin therapy. I'll say that perhaps when we treat them, more antimicrobial prophylaxis will be recommended, and maybe regular immunoglobulins will be the way to mitigate the risk of infection. So to summarize it, as you can see that after 14 years of follow-up, the response rate was 63%. We have already discussed most of the things. So the toxicity is also manageable, and the efficacy of 63% for multi-class refractory multiple myeloma is quite a lot, I must say it. That's all from my side. Thank you very much. Sorry for a little bit extra time. Thank you.
Thank you very much. Thank you very much, sir, for this session. Your session was very motivating, and we learned a lot from your seminar. So I just wanted to know that, like, IV and subcutaneous DARA both are available. So
Yeah.
what is your take? When do you choose subcutaneous daratumumab, and when do you choose IV?
You see, earlier what was my thought like that there are 2-3 subgroups which can benefit specifically by subcute. One is patients who are having cardiac involvement, particularly patients newly diagnosed. I'll go like patients who are having amyloidosis, because most of them will have cardiac involvement and they tolerate a large volume of daratumumab infusion very poorly. And those who are having associated coronary artery disease, poor LV dysfunction and all. That was one subgroup. And the other was where, like particularly in private sectors and all, where getting admitted every time or the time constraints is a little, I mean, getting admitted every time for this dara infusion or taking whole day of daycare, one bed of daycare and all is an issue. Like even in government sectors where number of beds in daycare is limited. So it can decrease that also to some extent. That issue means that is a cumbersome issue, that if you have 4-5 patients of daratumumab in your OPD in a day, it is difficult to arrange beds for them. So one medical indication, one I'll say was indication which was what logistic indications. But now the kind of data which is coming, it is being used in all kinds of newly diagnosed multiple myeloma. So if it is available, leave apart the cost part. Cost wise, right now the subcutaneous is little more. Leave about the cost part. I think that we can use it easily in any of the patients. It will be slightly comfortable for the patients because the time taken will be less, and it will be slightly good for maybe most of the medical setup, where the time taken will be much less. Patients will spend less time in the hospital. It will be win-win for the patient also and the medical facilities also. This is what my take is.
Thank you very much, sir. So we are also enrolled in the Alnatanab trial, which is being conducted by Pfizer. So currently, both of our patients are on the lenalidomide arm. Let's see, we have enrolled our third patient. What would be the therapy given to that patient shall be decided later on by them.
That's very nice. That's very nice.
We'll be able to share our experience later on with how.
That's great, Dr. Praviti. You and your center is improving in leaps and bounds. Is very nice.
Thank you very much, sir. So,
Is there any data on like long-term or secondary malignancies post teclistamab?
Well, I have not come across at least regarding the secondary malignancy with teclistamab as such any long-term data. The drug is new, as I said, that I am yet to use it. In India also, I don't think many of the people have used on international level. I don't think there also we have any kind of long-term data. You can see the minimal data I talk about, the Majestic 1 and 2. So the concerns are there. Let us see in the time to come. We will be more well versed with the risk of secondary malignancy with teclistamab. The risk of secondary malignancy is even if it is there to some extent, I don't think it will mitigate the efficacy or the use of teclistamab, because in myeloma, by the time teclistamab has been used as 4th and 5th line kind of therapy, you see patients, there are enough data of secondary malignancy with lenalidomide, enough data, but still we are using it for years because there are not too many options with us. The myeloma itself is still considered as an incurable disease. So if the risk is less than say 1% or less than even 2% kind of thing, 1 to 2% kind of things, I don't think it is going to deter the use of teclistamab. Looking at its efficacy, the 63% efficacy is in multi-class refractory. If you are using it second or third line kind of things, the efficacy is much more. Perhaps it may supersede even daratumumab.
So because basically it's a T cell directed therapy, and the side effect profile is more or less similar to what we see with CAR T. So just a thought came because there's a recent lot of data coming if on secondary malignancies after CAR T. So that's why I asked this question.
Yeah, absolutely perfect question. There's absolutely nothing wrong with the questions. I am just telling my
Yes, I agree with that.
inability to answer adequately your question, Dr. Ankit, because not much of data is
I think we have to wait for a few more years to get onto that data.
Definitely, you are absolutely correct. Absolutely.
Thank you very much, sir. So our next session would be evolving treatments and their clinical implications for first-line DLBCL patients in India. And the session shall be moderated by Dr. Ankit Batra, who is an associate professor in the Department of Medical Oncology, Hemato-Oncology and BMT, Cancer Research Institute, Himalayan Institute of Medical Sciences, Dehradun. I invite Dr. Ankit for inviting his panelists and then starting on with the moderation of the session.
Yeah. So, very good evening, everyone. Uh, this time not. Is my slides visible?
Yes, sir, it's visible.
Yes, they are visible.
Just okay. So, we'll be discussing about a small panel discussion about the evolving treatments and their clinical implications for first-line DLBCL patients, especially in India, with a special discussion around polatuzumab. So, we have our panelist, Dr. Vishnu Sharma. He is a senior consultant and hematologist and associate professor at SMS Medical College, Jaipur. We have with us Dr. Shalabh Arora, consultant medical oncologist at Ujala Singhas Hospital, Haldwani, Dr. Avriti Baveja, and we have a special expert today, Dr. Prakash Singh Shekhawat. He is a senior clinical hematologist in Jaipur. So I'll briefly discuss a few cases and ask about your thoughts. What are your thoughts on those cases and how would you like to manage in our current scenario, especially in India? So we have our first case that is a 48-year-old male who presented with abdominal pain and lower back pain and weight loss for 3 months. And on physical examination, yeah, there was palpable nodes in abdomen and flank tenderness. On labs, his LDH was elevated. A CT was done, which showed thickening of the stomach wall, multiple enlarged lymph nodes, and a mass in the right kidney. And an upper GI endoscopy showed a large gastric mass, which was biopsied, and it came out to be a high-grade DLBCL. It was a non-GCP subtype, c-MYC positive on IC along with BCL2, and FISH was negative. So it's a high-grade double expressor DLBCL ABC subtype. The patient is young and with a good performance status and a high IPA score of 3, stage 4 disease. So there are few clinical challenges. I'll ask Dr. Vishnu, how do you decide the predicting factors which are the patients who are at high risk of progression on the first line therapy, and how do you feel that these are the patients who might not do good even with our job?
See, the most important thing in any malignancy is disease biology. For example, in this patient, the patient is having c-MYC and BCL2 positivity on IHC. So he is double expression and could be double hit also. So the fish is necessary to establish the diagnosis of double hit, whether it is double hit or uh, double hit lymphoma is there or not. So the most important is disease biology, then disease stays. So the IPI parameters like stays, bulky node is there or not, what is the LDS status, performance status is also important. And at the same time, the patient's like organ function reserve is also important. For example, if someone is having cardiac disease with poor LV functions, so these are the patient which requires different strategy of treatment.
Yeah, I totally agree with that. And so basically, once a patient is coming, you take these type like cell of origin, double expressor or double hit, and other physical parameters into account before planning and thinking that who is at high risk of progression.
Yeah, yes.
So, uh, like, I'll ask Dr. Shalabh, uh, like when you see these factors, do you see that the treatment outcomes in these kind of scenarios like higher IPI or ABC or double expressor lymphoma do really matters in clinical practice apart from the clinical trials? Dr.
So
Shalabh?
basically, yeah, I hope I'm audible.
Yes, audible now.
Yeah. So this is clearly a high risk patient, like Dr. Vishnu has just mentioned. double expressor phenotype is obviously there. So in this patient, I would probably not, I mean, I would think that R-CHOP is going to be suboptimal in this case. And since he's not clearly double hit, so we can't really discuss DAR epoch or a more intensive regimen of that kind. But over here, this is probably space for where the, polatuzumab's that 8 to 10% extra benefit should be given to the patient. And in this specific case, I would push for that.
So suppose if it is a double hit,
Hmm.
other scenarios remain same, then you would consider DAR epoch or POLA-based regimen.
So in double hit, I would go more towards DAR epoch, since this is a young fit patient otherwise, and we have more experience with the DAR epoch. And I know there's not a very good prospective data, but retrospective analysis do show, and now I believe there's a considerable amount of data, probably a meta-analysis as well, which says that these patients do better with a more intensive regimen.
Maybe I would like to have thoughts of Dr. Prakash on the same point, that higher IPI, non-GCP and double hit. So DAR epoch versus POLA-based regimen in 2024.
So if it's a double hit, then I will definitely go for DAR epoch. Otherwise, in this case, I will choose Pola R-chip, considering the non-GCB nature, considering high IPI and expressor and stage. So if it's a hit, then I will go for a DR epoch. But coming to this, that cell of
So I
origin.
think that
Yes, Ankit, go.
no, please go ahead.
So cell of origin is very important. We are so limited to only two, that whether it's a GCB or ABC. But now if you go by molecular further subtyping, this guidance trial which has been published 2023, they have shown that cell of origin is very important. They have added different drugs like decitabine, they have added lenalidomide, ibrutinib after second cycle, from second cycle. First cycle blanket R-CHOP. From second cycle onwards, they have added another drug depending upon the different molecular subtype, and the difference is huge. So we
I think
currently are not able to go that far, but we can do ABC and GCB. So we can add polatuzumab definitely wherever we think it is possible.
Yeah, I think as of now, we have to rely on these factors till the time GEP comes into common practice. So, Dr. Avriti, I think the consensus is there, but would like to ask your thoughts also. Like in 2024, how would you like to treat this patient currently? You are not audible. Hello.
I totally echo with the thoughts of all the other panelists. If logistics is not an issue, I would preferably go for the Pola R-chip option. And if it is a double hit lymphoma, I would plan an RDA epoch. Otherwise, I may go for R-CHOP.
So suppose this patient is diabetic and having grade 1 peripheral neuropathy, then your treatment would still be same, or regarding the toxicities of peripheral neuropathy and other thing you would like to change, or you will just start and follow clinically whether it is the peripheral neuropathy is increasing or not, and then accordingly you will do, or from the baseline itself you would like to avoid polatuzumab.
So first of all, I'll try to use Pola in the first choice only. And then if the patient is not responding good, and if the patient is, not responding, if the patient is having toxicities, in that case, I may, modify or may skip.
So I think the consensus is there for high risk patient, especially higher IPI and ABC subtype or other risk factors. Pola is the way forward. And with all these recent advances in the diagnosis and treatment, Pola R-chip is the first line in 2024 with all the patients who can you afford this drug and there is no logistic issues. But still, if logistics are an issue, I think R-CHOP still holds the fort. And these are the factors which we use in our clinical practice. A few slides about the POLARIX study. We can see that the PFS at 2 years, there is a delta of 6.5 with hazard ratio 0.73. And the updated result, which was presented in June 2022, again at 3 years, the delta has increased to 7.7. I think once we get another update, maybe this year or coming next year, we'll get to know much more better and long-term outcomes, because most of these patients, once they have progressed, they might have received POLA in the second arm, and we are not aware about the overall survival or benefit was there or not. So, should the choice of therapy be determined by IPI? We have been discussing that, and this is the answer to that. That the progression-free survival significantly vary with the IPI. If we see, according to the IPI, the progression-free survival and other survivals are decreasing tremendously, and definitely for higher IPI, especially IP 4 and 5, or maybe from starting from 3, we need something better to add on to increase the PFS on OS in our patients over and above RCHOP. So this was the forest plot for the subgroup analysis, and it clearly shows that yes, the benefit is there for IPA 3 and 3 to 5, and it is significantly better. So in the era where RCHOP was there for decades, and we have not been able to give any extra benefit in terms of PFS and OS by adding various number of drugs, be it ibrutinib or venetoclax or any other drug. But now Pola RCHIP has shown that yes, if the IPA is high, it is definitely uh, the patient needs a change of treatment, and Pola RCHIP should be there if it can be given in the logistic constraint. Secondly, what we were discussing is the type or the cell of origin. Then also we can clearly see that we know that NHL or DLBCL is not a single entity, it's a heterogeneous disease. And what Dr. Prakash was telling, that yes, we need better classifications, better tools to pick up these different subtypes and decide the prognosis accordingly, so that all those categories or mutations or other genetic alterations which are there, which makes the disease refractory or resistant, should be taken care with the use of other drugs directed towards them. So yes, a new molecular profiling technologies are coming, and they are identifying various numerous DLBCL molecules, so that better treatment can be tailored for them. And this is the same uh, slide showing that DLBCL is a heterogeneous disease, and we need gene expression profiling to differentiate subtypes of DLBCL, not only on the basis of cell of origin, but on other features also. And genetic subtype or a genetic nomenclature should be defined, so that we can easily differentiate upfront to say that whether the disease is favorable or unfavorable, and which all patients need escalation of treatment, and which are patients are favorable and they can be prevented from overtreatment. So this is a subset analysis from the POLARIX studies of PFS, and you can clearly see the ABC subtype, which was benefiting the maximum. There, the difference and the quantum of difference is very high. The hazard ratio is 0.34. The patients, the 2-year PFS with Pola RCHIP was 85% as compared to RCHOP was 56. So almost a 30% difference. And the difference was very minimal in GCP. The curves are overlapping. And if you see the unclassified, then the difference is still there. So the difference is mainly because of ABC. Any young high risk features and ABC subtypes coming to my OPD nowadays in 2024, I am definitely going to counsel them for Pola RCHIP. And the clinical benefits of again the Pola RCHIP versus RCHOP in different genetic subtypes beyond the cell of origin has also been seen, and it has been shown that yes, the EZB, MCD, and undetermined subset shows a trend of higher 2-year PFS with Pola RCHIP than with RCHOP. So coming on to our second case, we have a 61-year-old widow female patients with newly diagnosed DLBCL. She presented with bilateral neck swelling, fever, moderate weight loss over 4 weeks with a PS of 2, comorbids of hypertension, diabetes, which were controlled on medications, and a PET CT showed hypermetabolic diffuse lymphnopathy with bone marrow was involved, elevated LDH with a very high IPA score of 5 and a CNS IPA of 5. And the biopsy also showed aggressive CD20 B cell lymphoma which was showing on ISC BCL2 positive, MYC positive, and Ka67 of 90%. So it was a double hit DLBCL with a high K67 and elevated LDH stage 4. So these kind of high-grade B-cell lymphomas are definitely a huge therapeutic challenge, especially in the elderly with comorbids. So, like, what is the optimal management you would like to do here? Uh, I would like to ask the views of Dr. Vishnu.
So actually, she is a relatively elderly lady with PS performance status of 2. So looks like compromised fitness. So I would go for R-CHOP in this patient. Double hit lymphoma, elderly, relatively unfit lady, R-CHOP. Along with CNS
So,
prophylaxis,
yeah.
CNS directed
So,
therapy.
because of the comorbids and the age, you would not like to consider the
DAR-CHOP.
POLA-based regimen, maybe a modified POLA-based regimen.
It can be considered, but actually it is double hit lymphoma. So in the trial, double hit lymphoma patients were not like was there. Not these patients were not there. So the trial was not uh, giving the like data towards double hit lymphoma. So
So,
if
Dr.
patient is
Shalabh,
fit, double hit lymphoma fit patient, DER EPOC. If unfit patient, then R-CHOP for me.
so Dr. Shalabh, this patient not fit for DAR epoch, you would also like to go with the R-CHOP, or you would like to wait for the data for POLA to come in these kind of scenarios?
So I think I partly agree with Dr. Vishnu that the data for this particular type of patient is not very robust. But having seen that even by cell of origin, if we just for for a while we ignore the fact that this patient is double hit, by cell of origin itself, this patient becomes eligible for polar R-CHIP. So this is a clear case where I think polar R-CHIP stands above R-CHOP or DA R-EPOC.
Yeah, so I agree with both of you. Data is of paramount importance in any clinical setting in oncology. But I think to generate data for every setting, it takes a lot of time. And with the available data, I would also like to consider polar-based regimens, extrapolating data from the polarics that yes, in the higher risk or poor prognostic factors with the uh, high-grade DLBCL, it has shown better outcomes in non-double hit patients or other settings. So similarly, I would like to extrapolate data and use in these kind of patients because I know this is an elderly lady, widow with a lot of complications. If she relapse, she's not going to make it because she's not fit for any kind of maybe transplant in second line of settings. So, like I'll move on and ask Dr. Prakash his views on like tolerance of intensive regimens in elderly or borderline elderly patients with comorbids.
No, I completely agree with Dr. Salav and Ankit both. I will personally go for Pola combination in this setting. Pola R-CHIP and R-CHOP both are approved for stage 4 DLBCL and both are category 1 in NCCN. So either of the two can be used, and contemplating that Pola is stronger, it's a better agent, another monoclonal antibody, it is likely to give us a good result considering the aggressive nature. And PFS is more important, as you rightly said. The second thing, that if we can manage the febrile neutropenia part, then somehow the dose adjusted epoch is relatively easy to administer. There is a big fear in our mind that dose adjusted epoch is not easy to give it. But,
So I
but
think it depends on patient to patient and not just on the age
yes,
to
it doesn't depend
decide.
on the age. Very good.
Yeah. So, Dr. Avriti, this patient is at higher risk of CNS relapse, but considering the data available and the uh, like whatever discussions recently going on whether to give CNS prophylaxis or not. So, what would you be doing in this case, and what are your thoughts on CNS prophylaxis? Dr. Aviti, you're not audible.
So in case I will go for all the speakers of panelists have said that they may have a variation in the choice of therapy. For example, if the patient is being planned for RCHOP at this scenario, I would, won't give the, I will add intrathecal methotrexate therapy for the patient. And or even with the RDAPOC, I will try to add the IT methotrexate rather than going for IV methotrexate for CNS prophylaxis, because maintaining the dose schedule with minimal neutropenias, with minimal interruptions would be a choice. And data also suggest that either we are going for IT or IV, we don't have much differences in the outcomes of the patient. And if I feel, and depending upon the responses, I may go for IV methotrexate in the later phases.
Okay, so even if you think that prophylaxis is needed, you will prefer IT one.
Hmm.
Okay, so there is controversy around how best to define and treat high-risk DLBCL patients, and various regimens like DAR-EPOC or R-CHOP or POLA-CF. We have these options. Definitely, extensive head-to-head data is not available. And should a different treatment approach should be used for high-risk patients? The answer for this is definitely yes. But what is optimal treatment is not yet defined. And I think we are not going to get any RCT on these 3-4 regimens. So we have to decide on the basis of patient to patient, and on the basis of experience of handling DREPOC or toxicities of other regimens, including POLA. And I think these are the factors which defines or helps in deciding the regimen. So we have select recent studies in aggressive B-cell lymphoma looking at the outcomes of patients with high-grade B-cell lymphoma and double hit or triple hit lymphomas. And I think most of that has been tried with various regimens, and not much difference or significant or statistically significant difference in terms of 2 years or 3 years EFS or PFS or OS. And we are still in that controversy what to use. Regarding the DER epoch and RCHOP for the frontline DLBCL, we have this CalGB 50303 trial, which does not show any overall survival benefit, although there is a significant PFS benefit, but that has not translated into a OS benefit. When we look about the POLARIX subgroup in the double expressor and the double hit subgroup, we can see that for a double hit, the benefit was not there in between the two arms, and it was like favoring the RCHOP. Or for double expressor also, it was like more towards POLA. So the answer with this subgroup analysis or the hypothesis to generate is still not clear, and it is on depends on patient to patient and the physician and the clinician to decide which patient will be better responding to which kind of therapy according to the personal and the logistic conditions. So we'll move on to the third case. Here it's a very elderly 71-year-old male with newly diagnosed DLBCL, and it presented with the right side swelling and discomfort with mild dysphagia, unusual snoring, and no systemic symptoms. Although he was elderly, but was in a very good performance status, nil comorbids, and PET-CT showed a hypermetabolic mass of 5 into 2 centimeter in the right palatine intestine and right submandibular lymph node. And the biopsy showed diffuse infiltration of large B cells, which is a GCB subtype with the Hans algorithm, and the fish was negative. So it's a stage 2 IPI 3 71-year-old male with elevated LDH and a CNS IPI of 3. So in these kind of scenarios, what is the accurate predicting subset who may not be cured with RCHOP? Maybe Dr. Shalab can take this.
Elderly patient, I would be very concerned about the toxicity part of it. And since this is stage 2, I would probably start him with RCVP or R mini chop, and if he tolerates well, then add on anthracycline. Like if I have started with RCVP, then add anthracycline, and then do the rest of the cycles, including anthracycline.
Yeah, I think everyone will echo with that. Like toxicity would be a major concern, and everyone would like to go slow and then escalate as per the tolerance. So, just a quick comment from Dr. Vishnu about the like high prevalence of the disease, comorbids, and cardiac events in this patient. What is your experience in your clinical practice, like patients in the age group of 70 and 80? Dr. Vishnu?
So, see, the cardiac dysfunctions are very common at this age. So, I would use R CVP if cardiac dysfunction is there. If cardiac functions are normal, then R mini chop.
Dr. Prakash, have you ever used or like commonly using lipodox in place of doxorubicin in elderly or patients who are like otherwise cardiac functions are fit, but they are elderly and prone for cardiac events?
Not frequently. I've used for two of my recent patients. I'm not using frequently. But in this case, I will go with R mini chop, 4 cycle followed by 2 cycles of Rituxi alone. As per the flyer trial, they have shown for limited stage 2, 4 Archer followed by 2 cycles of Rituxi maintenance. So I will, if I'm using R mini chop, then I will give 2 more cycles of Rituximab only.
Any thoughts on other regimens like BR or RLN? Any would like
No,
to comment
no.
on that?
Upfront, I won't be going for BR in this case because
Okay.
it is not very deranged profile. So kind of profile likely to tolerate R mini chop.
Yeah, I think the patient as of now is fit and okay, but
Yes.
susceptible candidate who can have toxicities. So, Dr. Avriti, do you routinely perform comprehensive geriatric assessment or any other tool to help with treatment decision in these kind of elderly patients? You're not audible.
So, see, it is very difficult to go for a complete geriatric assessment scoring. So what we do is we just do a rough estimate of on the various parameters related to the frailty, related to the support system, and the other comorbidities. If everything is okay, then we proceed with the therapy accordingly.
So, not because of the disease, but because of the age and the comorbids, there is a lot of other unmet needs also which needs to be considered for improving the outcomes in this older and unfit patients with DLBCL. And we need to have better tools or uh, to refine evaluation of these fitness and differentiated approaches in the elderly and unfit patients. As most of the panelists have told that they would like to start with RCVP or R mini chop and then escalate. And also we need in future effective interventions or the precision medicines and individualized therapies and also to prevent toxicities. So these attenuated regimens like R-CHOP, R-CVP, or R-mini-CHOP are an established standard of care for these elderly patients. And there's a lot of retrospective data on the using of lipodox also in place of doxorubicin. The outcomes are definitely poor as compared to those with the young patients, and the 2 year overall survival is usually 10% difference in these elderly patients, and we need better therapies which are safer and with equal efficacy for these kind of patients. When we look at the Polarix subgroup analysis according to the age in the elderly subgroup analysis, the PFS is slightly better. The 2 year PFS is 77 versus 67 in the Polar R-CHOP versus R-CHOP in the elderly patients. So there is almost a 10% 2 year PFS benefit when seen here. And similarly, the overall survival at 2 years was also 4% different. It was 86 versus 82%. So, if a drug in elderly population is showing 4% OS different at 2 years, definitely is going to do well in future. And the risk of progression, relapse, or death was lower with Pola R-CHOP versus R-CHOP in this elderly population. Maybe a longer follow-up and the toxicity pattern follow-up at 4 or 5 years would give us a better picture. Moving on to
I
our
just
last
wanted to
case.
add one point. Uh,
Yes,
Dr.
please.
Ankit, I just wanted to add one point for considering like in such scenarios, uh, I would like that more studies should be conducted in a pattern of an escalated therapy. Like for elderly patients, our first therapy should be the best therapy. So maybe after 2 cycles, we may assess the responses of the patient, and if the responses are good, then we may continue with the either R-mini chop or other therapies. And in that scenarios, if it is not, then I think so we should pull up with the datas of using Pola in the frontline settings only in a form of escalation.
Yes, I
Because
agree with that. So I think point well taken. We'll move on to our last case. It's a 32-year-old young male with who presented with fatigue, night sweats, and an unintentional weight loss for 3 months. That is the B symptom. And on evaluation was found to have HIV positive with CD4 counts of 350 cells per microliter, with well controlled viral load, no prior history of lymphoma or any other malignancy, and has presented with enlarged cervical and axillary lymph node with mild splenomegaly and no neurological symptoms. His LDH was elevated on labs, and the biopsy showed high-grade DLBCL, non-GCB subtype with double expressor, but FISH was negative. His PS was good, and EBV was also positive. So we have a 32-year-old male HIV positive patients with high-grade DLBCL, double expressor, non-GCB, stage 4, with a IPI score of 3. So usually, Dr. Vishnu, what are your like management in these kind of patients, and like the treatment caused immunosuppressions in such kind of compromised patients? What are your thoughts on that?
Like if patient is fit, no active infection, and like if patient is affordable, then in this case, I would prefer Pola R-CHOP, considering the high risk features, non-GCB subtype, advanced stage, high LDH, high IPI. Otherwise, R-CHOP. If patient is not affordable, then R-CHOP.
So, Dr. Shalab, do you think that these kind of patients are more susceptible to hematological toxicity? The data says points toward that, but what is your viewpoint and what is your observation in this?
I haven't had very much of an experience treating HIV positive lymphomas, but with whatever little experience, I feel basically the hematological toxicities are not that bad, but they are prone to more infections. So even if their CD4 counts are good, their HIV load is low. Uh, so I would definitely add a good prophylaxis, even probably even before I start the chemoimmuno regimens.
So maybe a good prophylaxis and a close monitoring.
Yes, yeah.
Dr. Prakash, your thoughts on these kind of patients, are they tend to have higher risk of CNS involvement, or we can take in comparison to what we see in non HIV positive patients?
No, definitely they are at higher risk of CNS also, and we can't give much of immunosuppression. We need to monitor their CD4 count frequently. So this is a scenario where I am less likely to use polatuzumab. I'm not certain about this. So either I will use R-CHOP, and considering this stage 4, I think we may use short course REPOP also. But R-CHOP preferable for me rather than Pola R-CHOP in this scenario.
So these kind of special scenarios are usually excluded from clinical trials, and we have very limited data. Only few studies published from maybe from investigator initiated or retrospective data, what we have seen in most of these. So, Dr. Avriti, what is your experience in terms of prognosis in these kind of patients as compared to the non-HIV positive DLBCLs? You're not audible.
Most of the time when we're dealing with patients with HIV infections, we have to deal with other complications, hematological toxicities, and they may have some sort of intolerances to various therapies. So most of the times we see that it becomes very difficult to give the complete therapy or the complete doses to the patient, even when we are going with an R-CHOP based regime. And with polar R-CHP, since we don't know how the responses would be, because how this would reflect on the CNS or activation of origin of some new side effects can't be commented upon.
Yeah. So that was actually my next question. Just a quick take from everyone. Like, what do you think that in these kind of special scenarios, anything like interaction or any special precautions to be taken with if you are using ADCs like polatuzumab? Anyone can take that. Maybe Dr. Vishnu can take.
Okay. See, the interaction has to be kept in mind. For example, if ampicillin is a strong enzyme inducer, it should be avoided if patient is on ATT. Similarly, you should look for the drug interactions with ART also. So interaction like azoles. So interaction is very important. And HIV patient tend to have like multiple polypharmacies like azoles, ATT. So it should be considered while planning therapy.
Yeah, point well taken. I think he'll be on multiple prophylaxis and polypharmacies there. So definitely interactions is one which needs to be definitely checked and taken care of. So this was a retrospective analysis of Poralix and comparison of Pola R-CHP versus R-CHOP in young patients with high-risk diffuse B-cell lymphoma. And here also the EFS at 2 years was uh, better with R-CHOP as compared to Pola R-CHP chip. But if we talk about overall survival, it was better with Pola R-CHP as compared to R-CHOP, and the PFS was comparable. So I think nothing much we can conclude from these kind of studies. It's the results are more or less comparable. A longer follow-up is required. What is important is the favorable safety profile. So in that case, the Pola R-CHP is much more favorable as compared to R-CHOP because the risk of infection, leukopenia, thrombocytopenia, anemia, and other more than grade 3 toxicities is significantly higher with R-CHOP as compared to Pola R-CHP. So once the results are comparable or similar, toxicities and safeties comes into play, and here the Pola R-CHPs gain over the 5-drug chemotherapy-based regimens. So I think that was all from my end, and Pola is a very good drug, especially in few scenarios where R-CHOP we know is not going to do much. The only issue is the financial toxicities. I think Roche will be better able to take care of that in 2025. So thank you everyone for joining this panel, and back to the organizers, Dr. Avriti.
Sorry, I just lost my connection. So thank you very much, Dr. Ankit, for this moderation. Now, I would like to invite Dr. Anshul Gupta, who is the Director Medical Oncology at Medanta, Lucknow, for defining treatment landscapes in Hodgkin's lymphoma with brentuximab.
So, good evening, everyone. Am I audible and my screen visible?
Yes,
Yes,
sir.
Yeah. So, good evening, everyone, and happy Navratri to all of you. At the outset, I would like to thank Dr. Avriti for organizing this hematology update and giving me this opportunity to talk on Hodgkin's lymphoma, because a lot has happened in last 3-4 years in the management of Hodgkin's lymphoma, and I shall present a glimpse of it in this talk. So in this talk, I shall be discussing about the frontline treatment of Hodgkin's, how it has changed in recent past, relapsed refractory patients management, and post ASCT consolidation. So coming on to the frontline patients, we all know that the outcome of early stage Hodgkin's lymphoma is excellent with ABVD chemotherapy. But what we were not able to achieve was the management in the improving the outcome for advanced stage Hodgkin's, that is stage 4 and stage 3. And in that, almost 1/3 of the patients used to relapse despite giving the ABVD chemotherapy. And for many years, for almost decades, there was no convincing data of any particular chemotherapy regimen being superior to ABVD, be it Stanford, be it VCOP. Almost all regimens were giving the same results. So after around I should say 3 decades, the new drug that has come into the market for advanced stage Hodgkin's is brentuximab. And this was incorporated in the latest NCCN guidelines also, that in advanced stage Hodgkin's, either you opt for a ABVD 2 cycles or brentuximab AVD. We omit the bleomycin in this protocol, or the third is the checkpoint inhibitor, that is Nivo AVD. So these three, the 2 molecules have recently been included or added in the latest NCCN guidelines. That is, one is the brentuximab, which is a targeted therapy for anti-CD30. We all know that CD30 is positive in majority of cases of Hodgkin's lymphoma, and it is a targeted therapy against that. And Nivo is a checkpoint inhibitor that is also quite effective in Hodgkin's lymphoma. So these 2 molecules have recently been come into picture apart from ABVD chemotherapy. So I would just present few slides on the outcome of phase 3 echelon trial, which was the brentuximab trial. And this was a randomized controlled trial that divided patients into 2 groups. One group received brentuximab AVD and the other group received ABVD. They all received 6 cycles of chemotherapy followed by end of treatment PET. The inclusion criteria were predominantly all advanced stage Hodgkin's, that is stage 3 or 4 with ECOG performance status 0 to 2. And then they noticed what are the difference in outcome. So if we see compare the baseline patient characteristics, they were almost comparable. 664 patients in the brentuximab arm and 670 patients in the ABVD arm. And they were quite comparable in terms of their baseline disease characteristics like unarbored stage, IPS, ECOG performance status, B symptoms, everything. And based on this study echelon trial, they recently published overall survival benefit with brentuximab vedotin in stage 3 and 4 Hodgkin's lymphoma. This was recently published outcome data. So you can see in that when these patients who received brentuximab AVD as an upfront agent and on a 6 years follow-up, that revealed that initially there was only PFS advantage, but now after a long-term follow-up, what we can really be seeing is something very exciting, that the brentuximab AVD arm had an 6-year OS of 90, almost 94%, while ABVD has 89%. And this was significant. The p-value was significant. So definitely there was an overall survival benefit of using brentuximab in advanced stage Hodgkin's lymphoma on a long-term basis. And the reported difference in risk of death at 6 years is 41%. And that's quite significant for this patient group. Because if you remember in the outset, I told that almost 1/3 of the patients of advanced Hodgkin's relapse in later course of their disease. So if we see the PFS benefit was initially also there when they randomized in the Echelon 1 study, that in the short-term follow-up, there was definitely an evidence of PFS, but initially there was no OS advantage. But on a longer follow-up, after 6 years, they have shown that there was an OS overall advantage. And the reported difference in risk of disease progression or death is at 6 years is 32%, which is quite significant. Now, if we compare that, how many patients who were received brentuximab AVD later on received subsequent anti-cancer therapies at 2 years and at 6 years, what you can really see is that the patients who received brentuximab AVD vis-a-vis who received ABVD, the patients who received ABVD received subsequent more anti-cancer therapies in form of salvage therapies. Probably they relapsed more, and as a result of which they had to receive further salvage chemotherapy followed by an autologous stem cell transplant. And if we compare the risk of second malignancies, it was actually less in the brentuximab AVD arm as compared to the ABVD arm. You can see that there were 23 cases that were reported in the brentuximab AVD arm as compared to 32. And this is a critical issue, especially in the young population, more than in the, I should say, young adults, 18 to 35 to 40 years of age, because this was a big concern. They are young, they have to have around 30 to 40 years of their life remaining, and they shouldn't develop any second malignancy. So till now, the 6 years follow-up data, there is no increased risk of second malignancies with brentuximab. As we come to the adverse event group, we can see that the brentuximab AVD arm almost had a quite, I should say, there was no increased events of febrile neutropenia or infections as compared to ABVD. But there is one catch, that most of the patients who received brentuximab AVD also received GCSF. While in ABVD, we don't usually give GCSF in majority of patients. So the degree of neutropenia was slightly less in the brentuximab arm as in the protocol. Almost all patients received GCSF, but there were no neutropenia associated deaths occurred in patients who received primary GCSF prophylaxis prior to the onset of neutropenia. So this is one important take-home message while using brentuximab. Now, the 7-year overall survival ABVD versus brentuximab AVD, this was recently published in the ASCO, presented in the ASCO, and the overall survival benefit is still remained. And as you can see from the p-value is quite significant, and there was 38% reported difference in the risk of death at 7 years. And the PFS benefit also remained sustained with 32% reported difference in risk of death to progression at 7 years. So definitely brentuximab is a good, I should say, a drug which has really made a difference in the management of advanced stage Hodgkin's lymphoma. So which patient population you should really be contemplating for using brentuximab? That's another important question for clinicians, which we should be knowing, because it's a costly drug. We can't liberally use this drug in all advanced stage Hodgkin's. So there are some few data points that have come into light when we compared it, that which patient subgroup. So stage 4 patients, definitely it should be considered. Patients with baseline extranodal sites more than 1, it's again another group in which it should be used In fact, I in my clinical practice usually prefer brentuximab in patients who are having an extranodal disease, because these patients tend to relapse on longer follow-up. And age less than 40, that is the young patients, or the patients who had a age less than 60. So in all these patient groups, there was a risk of reduction of death due to disease if they use brentuximab upfront. So these are the subgroups which we should be considering using brentuximab upfront in advanced stage Hodgkin's lymphoma. So the summary of Echelon-1 trial was OS is an important clinical benchmark, and OS advantage has seldom been demonstrated in any of the first-line Hodgkin's lymphoma trial. And ABVD, though still being considered as a therapy of choice as in frontline advanced Hodgkin's, but definitely the outcome is not satisfactory, and there is definitely a scope of improvement in that. And brentuximab exactly fits into that place with 38% decrease in risk of death and manageable safety profile. So that's the take home from the Echelon-1 trial, which I presenting. Now moving the ball forward, what's the outcome for relapsed refractory patients of Hodgkin's lymphoma? And in this study also, in this subgroup of patients, we saw that brentuximab definitely has a role, and the dose for brentuximab is higher as compared to the patients in which we use it as a upfront. In relapsed refractory cases, it's 1.8 milligram per kg Q3 weekly as compared to other lines of therapy. And the primary endpoint was the overall response rate, while the key secondary outcomes were the CR rate, PFS, OS, and safety. And you can see that ORR was 75% with 34% achieving CR with etc. And 94% of the patient achieved some tumor reduction, and majority of the patient achieved more than 50% tumor reduction in the cases in which they received brentuximab as a single agent. So definitely it is effective. And apart from it's a targeted therapy as compared to the conventional chemotherapy, the salvage chemotherapies like GDP or DAP regimens or ICE regimens, which we are conventionally using in relapse Hodgkin's lymphoma. And in heavily pre-treated ASCT failure patients, the overall response was 5.7 weeks with a CR rate of 12 weeks. So definitely it has a role in the in these patients, and these are all poor patient groups. You don't really expect a dramatic outcome or very satisfying outcome. So the probability of OS in this patient group was really the median OS of 40.5 months with a 5-year OS of 41%, while an PFS of 22%. So coming on to the time to response. So this was a median time to objective response was 5.7 weeks. And phase 4 study in relapsed refractory ASCT ineligible Hodgkin's, it was 6 weeks. So the time to response is an important consideration when treating patients with advanced disease or bulky tumors and patients proceeding to ASCT, because the more that you give the chemo, there is difficulty in mobilization of the stem cells, and more it becomes a tedious task for us to perform a ASCT. So in real world studies, etc. has been shown to be treatment options for relapsed refractory Hodgkin's with a potentially curative outcomes with or without subsequent SCT. etc. has demonstrated superior real world outcomes to common alternative treatments, and it provided an effective pre-transplant therapy for over half of the eligible patients, and it is very well tolerated in real world. Now moving on to our third part, that is the post ASCT consolidation, because many of the studies are now promoting that post autologous stem cell transplant, these Hodgkin's lymphoma patients do require a maintenance therapy, or you can say a sort of a consolidation therapy. And this was the trial, Athira trial design, and it randomized. It was a double-blind, placebo-controlled phase 3 trial to assess whether etc. improved PFS in patients with unfavorable risk relapse or refractory Hodgkin's when given an early consolidation after ASCT. So many of you who are sitting in this audience must be seeing these patients, and the eligibility criteria for this was the refractory to frontline therapy, relapsed within 12 months after frontline therapy, or relapse more than 12 months with extranodal involvement. And in these patients underwent an ASCT followed by the one group received an ascetris consolidation while the other group didn't receive anything. The dose was 1.8 milligram per kg Q3 weekly up to 16 cycles. So almost it was a therapy lasting for around, I should say, a year or so. And what they saw that at 5 years, brentuximab vedotin continued to provide a sustained PFS benefit. So 59% vis-a-vis 41% in the placebo arm. And the PFS benefit was really significant in this group because these are the patients minded that who underwent a autologous stem cell transplant. So definitely there you are not left with any treatment options if the patient relapses post autologous stem cell transplant. So definitely if this therapy can improve the survival, progression-free survival post autologous stem cell transplant, then it's really a win-win situation for this drug. And this drug, despite being the bad risk factors, it still showed benefit. So risk factors, what were the risk factors in which it showed benefit? Was the primary refractory Hodgkin's or relapse within first year of post-transplant, extranodal disease at pre-ASCT relapse, B symptoms at pre-ASCT relapse, and 2 or more previous salvage therapies. So these are all the high risk factors where you should really contemplate for patients to be receiving an brentuximab consolidation post autologous stem cell transplant. And one thing which I had seen is that in primary refractory or extranodal disease or B symptoms, so these patients usually tend to do not very good in post autologous stem cell transplant also. So the peripheral neuropathy was one of the most important significant side effect of using brentuximab that constituted almost 50% or half of the patients developed it, but it is of grade 1 or 2 severity. It was not grade 3 or 4 where the patient, it becomes a troublesome for day-to-day routine activities, and the patient tolerated the procedure quite well. And after 5 years of follow-up, 90% of the patients with peripheral neuropathy in etc. reported resolution or improvement. So these are the recommended doses. As I previously told, that for previously untreated patients, the dose is 1.2 mg per kg. In relapsed refractory cases, it's 1.8 milligram per kg, and it is approved for other cancers also, lymphomas like ALCL, it's one, and the other is cutaneous T-cell lymphoma. So it is effective in both the cases. So the key conclusions of ATHERA were post-ASCT consolidation with brentuximab for patients with classical Hodgkin's provide greater PFS than placebo. PFS benefit observed with BV was maintained until study closure. PFS benefit was most pronounced in patients with more than equal to 2 or 3 risk factors, and almost 47% of the patient in the placebo arm received brentuximab as subsequent therapies. So you can imagine that the patients, almost half of the patients received brentuximab as a salvage therapy in patients who relapsed post-ASCT. So to summarize my today's talk, BV-ABD is the first regimen to show an improvement in OS versus ABVD in a direct comparison in patients with previously untreated Hodgkin's. Echelon-1 study sought to improve upon ABVD by replacing bleomycin with the novel agent BV. And OS benefit with BV-ABD was coupled with fewer second malignancies versus ABVD. The SGN 350003, 38% of patients who received CR with etc. had remained in long-term remission for more than 5 years. So you can imagine the amount of benefit. And ATHERA trial, the post-ASCT consolidation with BV for patients with classical Hodgkin's lymphoma provides greater PFS than. Thank you for patient. I am ready to take on the questions.
Thank you very much, sir, for this wonderful session. So basically, I just wanted to know, sir, your experience regarding use of combination therapy of brentuximab plus nivolumab in cases of elderly patients, frontline or in relapsed refractory scenarios.
I have used brentuximab nivo combination in relapse setting, not in a frontline setting, definitely. But the financial toxicity is quite high in such cases, though the regimen is well tolerated. Brentuximab nivo is well tolerated, and there are not that much significant side effects, but the cost of the therapy escalates to a degree that where the patients usually can't afford. But the point remains in I usually keep this regimen, brentuximab nivo regimen, in patients who are really bad disease, primary refractory Hodgkin's lymphoma. In majority of patients, my salvage regimen with brentuximab is bendamustine. So bendamustine works quite well. The only drawback is that we fail to, there is a difficulty in harvesting the stem cells when you are using brentuximab benda as a salvage regimen. So the stem cell yield decreases sharply. So that's my take. But in upfront setting, I still stick to either brentuximab AVD, and the data from the SWOG trial is coming where they have used Nivo AVD, which is another promising regimen for advanced stage Hodgkin's lymphoma.
Sir, and one more thing, with the number of cycles of brentuximab plus Nivolo, so what has been your number of maximum cycles for brentuximab Nivolo combinations, and what were the bothersome side effects towards the end of the therapy? Because most of the time, when in relapse scenarios, I have started facing side effects after maybe 8th or 9th cycle of the combination, and there is no particular definite duration. If you are not planning for a transplant, at times we have to give it for a longer duration. So what is your maximum duration of giving this therapy?
So what I do, if you ask me, I don't give this brentuximab nivo more than 6 cycles. One important thing. And the second thing is that if the patient, I do an interim PET post 3 cycles, if you are not contemplating for a transplant, because I usually do a PET CT. If you are contemplating for an autologous transplant, I usually do a PET CT after 2 cycles of brentuximab nivo itself. And if the patient is supposed to be in CR, I just straight away take for autologous transplant. If we are not contemplating an autologous transplant, then definitely 6 cycles are sufficient, followed by either you can use a Nivo or Pembro maintenance therapy, or you can use the brentuximab maintenance or consolidation, whatever you call, just like in post ASCT consolidation. We give it as a single agent if the patient is in CR. If the patient is not in CR, despite 6 cycles of these salvage therapies, then it's a difficult situation. Probably you should be counseling them for an LO SCT rather than taking them for auto SCT.
Thank you very much, sir. Thank you very much
Thank
for
you.
your educative session. So I'll be inviting Dr. Akash Khandelwal, who's a consultant hemato-oncologist and BMT physician at Fortis Shalimar Bagh. And this is our last session, and he'll be discussing about the role of FCM in iron deficiency anemia. I welcome you, Dr. Akash.
Yeah, hi. Thank you for the invite. You cannot start because host is. Can we allow the video as well? Because it is showing that it is disabled by the host. Hello.
Hello, technical team. Hello.
Okay. So yeah, hi. Thanks for the invite. I'll be discussing today regarding the role of FCM in management of iron deficiencies. Can we have the slides, please?
Yes, sure.
And thank you, Dr. Avriti, for the kind invite. Really educative sessions ongoing, and very well planned and very good discussion being done.
It's a lot, Dr. Akash.
Thank you. So, as I said, I'll be discussing regarding the iron in iron deficiency anemias. So let's start. Next slide, please. Yeah, so we all know that the anemia is very much prevalent, and the most common cause of anemia is iron deficiencies across all age groups. Women are the most common, subgroup in which the anemia is more common. Pregnant women, non-pregnant, overall, there's a lot of anemia, especially amongst women as compared to men. Millions of cases in India and across the world. Next slide, please. So yeah, mild, moderate, severe, the classifications of anemia. In a non-pregnant and pregnant state could actually vary because there is hemodilution during pregnancy that leads to a different definition. Else, it is standard less than 8 is severe, 8 to 11 is moderate, and 11 to 12 is mild anemia. Next slide, please. So yeah, iron deficiencies can be of various types. It could be an absolute iron deficiency in which there is no low saturation TSAT and ferritin, which is also low, while there could be a functional deficiency where the transferrin saturation is low, but ferritin could be a variable. Iron sequestration where saturation is low and again ferritin could be normal to elevated, and mixed could be a functional along with iron deficiencies where TSAT can also be low, will be low, and ferritin can be low to normal ranged. So these are on the right. If we see, these are some causes of functional iron deficiencies. It could be anemia of heart failure, anemia of malignancies, anemia because of renal dysfunction, CKD, and bone marrow related problems as well. Next slide, please. So this is the when we come into discussion of a functional iron deficiency and absolute iron deficiency. This is the basic pathognomic or pathological features. So yeah, one in an absolute iron deficiencies, one will have a reduced intake, reduced absorption, and leading to decreased supply in the pool and lead to decrease in function in the absolute storage and also low hemoglobin. So absolute iron deficiencies will have low iron stores as well, along with low functional iron. Whereas in a functional iron deficiencies, the iron deficiencies because of less functional iron because of the hepcidin. Whenever there is inflammation, leads to rise in hepcidin, which reduces the export of iron from the storage pool by reducing ferroportin, leading to a functional iron deficiency. So the iron stores are normal, but the functional pool or the available iron in circulation is actually reduced, leading to decreased TSAT. Next slide, please. Again, this will discuss about anemia in heart failure patients. It could be an absolute deficiency. It could also be a functional deficiency. The functional deficiencies I'll talk about arises because of the cytokine, leading to increased hepcidin, which again decreases ferroportin, leading to JAK-STAT mechanism and leading to overall decrease in the saturation and the overall circulation of iron in the blood cells. Whereas the absolute iron deficiency in a heart failure could be because of reduced intake, anorexia, intestinal edema, and leading to overall decreased hemoglobin. Also because of blood losses, because of aspirin, antiplatelet, anticoagulant. So this is one of the most common references that we see from our colleagues and also in OPD is the persistent iron deficiency anemia, even on iron supplements. Especially in heart patients, one has to rule out any GI bleeding because of anticoagulants, antiplatelets, also because of some cardiac cachexia leading to poor absorption of iron in circulation. Next slide, please. So yeah, iron deficiency can have its stages. First is, iron deficiency, but there is no anemia. First two stages are that, after which there is anemia along with low iron, low serum iron, low transferrin, and low transferrin saturation. So these are considered as 5 stages of iron deficiencies. One mostly can be in first 1, 2, or 3, or 4 stage, and accordingly, one can be benefited by using iron. Next slide, please. So we'll discuss the approach to anemia. One could be a microcytic hypochromic anemia. If the retic counts are high, one should consider an HPLC and rule out thalassemia. If there is low retic count and microhypochromic anemia, then one should consider strongly iron deficiencies or functional iron deficiency or other causes of hereditary iron deficiencies, in which one could be, iron refractory iron deficiency anemia, IRIDA one can have. Other, if it's a normocytic normochromic number, then we can anemia, then we can again look at the retic count. And if the retic count is low, again, we could be a functional iron deficiency, look at serum ferritin and transferrin saturation, or could be a bone marrow related pathology. If the retic count is high in such cases, one should always rule out hemolysis. Similarly, in macrocytic anemia, if the retic count is low, B12, iron, these has to be ruled out. Folate deficiency, myelodysplastic syndrome, bone marrow related pathology. If macrocytic anemia is along with increased retic count, one has to rule out hemolysis. Next slide, please. This again shows a picture on why a functional iron deficiency occurs and what is the exact role of hepcidin. So hepcidin is something which is increased in cases of inflammation, leading to decreased absorption of iron, leading to low iron status, and also low release of iron from the stores by decreasing ferroportin, leading to decreased production of RBCs and increased destruction of RBCs also because of the inflammation. So this is actually very much common. It's in hospital settings. It's one of the most common causes of iron deficiency anemia in a hospital setting. Next slide, please. So yeah, this again highlights a difference between the absolute iron deficiency and functional iron deficiency. So if the hepcidin is high, it again decreases the overall absorption and utilization of iron, leading to iron deficiency. If hepcidin is low, it leads to an increased absorption of iron, leading to iron overload. This can also be seen in thalassemics, which because of ineffective erythropoiesis causes reduction in the hepcidin, leading to increased iron, and also in thalassemic traits. This is the reason why thalassemic traits have a higher iron concentration than a normal population. Next slide, please. So coming to what is the total deficit of iron? After defining it's an iron deficiency anemia, how to go about it? Next slide, please. So this is the study which actually discusses about the iron deficiency anemia, and more or less the iron deficient is near around 1500 mgs in all the study group across various cohorts. Next slide, please. So if more need of retreatment when iron is given of 100 mg when compared to 1500 mgs. This is a very good data shown in a study where there is 5.6% we required retreatment compared to 11.6 who was treated with 1500 mg versus 1000 mg. So this is actually very important. Most of us tend to treat it via single dose of 1 gram IV iron, but that could be sometimes counterproductive because patient will require a repeat iron transfusion after 1 month or 2 months. So one should always do a iron deficit and then calculate and give the dosage accordingly. Next slide, please. So again, the iron deficit becomes a very important thing, and across all the studies, 1500 mg has been a very close number for most of the patients with iron deficiency, especially in the adults. So 1500 mg again helped in rapid onset, robust increase in iron when compared to 1000 mg, and a longer and increased raise in hemoglobin. Next slide, please. So yeah, 1500 is more suitable and definitely more long-term increase in hemoglobin when compared to 1000 mg dose. It could be 1000 1 gram direct dose of 502 vials, depending on what is your strategy of giving IV iron and the iron deficiency. Next slide, please. So how do you calculate iron? Next slide, please. We have discussed 1500, where this number has come from. So the basic Ganzoni formulation, suppose the weight is 60 kgs, the target hemoglobin is 12, actual hemoglobin is 6, that gives you 60 into 6. So that'll be 3600 into 0.24 plus 500. So this will be giving you a iron deficit, but it always underestimates a person who's actively bleeding. So this formulation can be actually not of much use in such cases where the bleeding is ongoing, and because the deficit will also be ongoing. Next slide, please. So yeah, these are the simple schemas to understand and calculate IV iron. One can go for body weight, one can be using Ganzoni's formulation, and one can be targeting accordingly. Next slide, please. Yeah, so coming to how the iron should be deficit. So in my practice, it's almost like 60-40, 60% goes for oral tablets, 40% goes for IV iron. Both options are always discussed with them, and one can choose accordingly. Patients who are treated with initial dose of 1500 mg had a lower probability of decreasing and receiving IV iron for next 1 month when compared to 100 mg. This is again study highlights the same, and most of them had a hemoglobin of 8 to 9. So it's not that the hemoglobin has to be 6 before you give it 1500 mg. Rather, one can target a higher number in a subgroup of moderate anemia. Next slide, please. So yeah, again, this study highlights how FCM compares with the other formulations of iron, including FCM and other IV irons. So FCM had lesser complications, lower number of injections, and overall better visits, better outcome in terms of rise in hemoglobin. Next slide, please. 1 in 3 patients received lower than recommended dose of 1500 of total IV iron, leading to poorer response in such cases. Higher IV iron dose within 3 weeks lead to reduce in further IV iron treatment for long term. That has been already discussed and again re-highlighted via various studies. Next slide, please. So this is the guidelines of various department, because anemia is being treated by various departments, whether it be gynecology, whether it be gastroenterology, hematology, oncology, nephrology, and cardiology. So in all cases, more or less, especially in anemia of chronic disease where there's functional iron deficiency, IV iron is the only mainstay treatment. The oral iron does not get absorbed because of the hepcidin. So such cases, IV iron is the way to go. And one can calculate accordingly, depending on the transferrin saturation, depending on the weight of the patient and the hemoglobin. Next slide, please. This again is the anesthesia guidelines, where the ferritin is important, the transferrin saturation is also important, and administer accordingly as per the need of the patient. Next slide. So in the next, we'll discuss about the IV iron therapies, how had things evolved over a period of time, because initially the formulation of IV iron which were available were not that promising and had its own complications in terms of reaction, staining of iron and everything. So this is how it has. Initially it was iron saccharide, then high molecular, low molecular, iron dextran, ferric gluconate, iron sucrose, ferromoxetol. FCM came in 2023. Iron isomaltoside came in 2020, and things have changed since then. Next slide, please. So again, this is the first generation iron dextran, high molecular, low molecular, ferric gluconate, iron sucrose. I fondly remember that when I was in MBBS, we used to study a lot about dextran. Then came sucrose, and then came iron isomaltoside. So iron isomaltoside was actually something, and ferric carboxymaltose, which actually changed the picture of iron, and it made things more convenient in terms of treating iron deficiencies with IV iron. Next slide. So this is difference between first and second generation preparation. So as I was saying about dextran, more allergic reactions, more painful, and multiple injections were required because the iron levels were low. Similarly, iron glucolate and iron sucrose had its own problems. Weak labile iron, only 200 mg of iron is given at a time, and it can have its reaction and subsequent toxicities. Next slide, please. The third generation came the iron isomaltoside, and the ferric carboxymaltose had a strong complex structure, less labile iron, less reaction, larger dose of iron can be given. in a shorter amount of period. Next slide, please. So yeah, iron dextran had a higher anaphylaxis. Iron sucrose has limited number, 200 mg, larger time required, more doses were given. Carboxymaltose is relatively very stable, less reactions, and higher dose can be given. Next slide, please. So yeah, this is actually what it is when it comes to molecular levels, and this is how one should go about it. One can choose as per the need. If cost is never a constraint, then one has to go for third generation or higher. Next slide, please. So next slide. So yeah, this is something which is less, can be given over 30 minutes, 20 to 30 minutes, has a less reactions, more amount of dosage, no reactivity, lesser reactivity, less immunogenic potential, and can be calculated and given easily in a daycare settings. Iron has to be given in a daycare setting rather than home or home care center because of the reactive nature of iron even in third generation. So in my practice, I always give patients iron in a daycare or an emergency setting. Next slide, please. So this again compares between the older generation, and there is no doubt in the fact that iron isomaltoside has a higher efficacy and higher overall side effect profile. Next slide, please. Coming to the indications of the study of IV iron across various indications, we have discussed anemia of chronic disease, functional iron deficiencies. Similarly, next slide, please. Anemia of cancer is a very important entity that we hematologists do and deal with it regularly, even a post-transplant setting, pre-transplant setting, during treatment. So this was a randomized ironclad study where ferric carboxymaltose actually reduced the need of anemia in patients requiring chemotherapy, even in a non-myeloid malignancies. So yeah, this was actually something with a randomized study showing the benefits of IV iron, and it actually was a very significant study because recurrent iron deficiencies and anemias will always be a problem in patients of malignancy, and actually giving IV iron reduce the need of recurrent blood transfusions. Next slide, please. So this again, as I discussed, giving IV iron was also a good, prospect instead of blood in such cases of malignancies, and it helped in maintaining hemoglobin with 0.5 above 0.5 gram per deciliter from the baseline. So yeah, IV iron is definitely one thing which has actually improved and the overall outcome in malignant cases with anemia, along with erythropoietin stimulating agents plus minus a blood transfusion. Next slide, please. So when compared to head-on-head with oral iron, the IV iron is better suited in anemia of chronic disease, where you have to, look into and treat anemia aggressively and frequently in terms of bleeding, in terms of cancer, where IV iron can actually supersedes oral iron, where the absorption is an issue, and such cases warrants ferric carboxymaltose in all cases of basically functional iron deficiencies, and in those cases where you need to correct IV iron faster or you are not able to tolerate oral iron because of patient profile. Next slide, please. So yeah, when compared with oral iron versus IV iron, was better outcome post surgeries because the overall absorption and overall increase and the increment in the time where the hemoglobin risen was better in IV iron when compared to oral iron. Next slide, please. So yeah, this again shows better ferritin and better overall outcomes in such cases where IV iron was used over oral iron, especially in patients of colorectal surgeries, which turn to bleed and turn to require recurrent transfusions, and also tend to complicate more easily. Next slide, please. In conclusion, we'll say that iron replacement actually has changed the setting, especially in oncology and functional iron deficiencies. IV iron has made a promise, and whenever using IV iron, one has to consider and calculate a functional deficit. More or less 1500 mg is the preferred dosing in such patients, irrespective of the levels of hemoglobin. Except in mild deficiencies, moderate and severe deficiencies definitely require a 1500 mg correction. FCM has hold promise, is a longer molecule in terms of it was discovered in 2013 and FDA approved. Larger randomized studies across all the age groups, be it pregnancy, be it heart failures, be it GI malignancies and other malignancies. And even Indian studies are there, which shows a good number of ferric carboxy maltose. So yeah, that will be it. And if there is any questions, one can discuss. Thank you.
Much, Dr. Akash. All the points are well taken. So I just wanted to ask you a question that in what scenarios do you prefer FCM, and in what scenarios do you go for iron isomaltosite?
There's no actually difference as such. Maybe in pregnancy, I only consider FCM because of the studies are more for FCM. But as such, there is no preference in both of them. Both of them works well. And iron isomaltoside can be given on a higher dose when compared to FCM. So if I'm trying to give a single dose, I can also be inclined towards iron isomaltoside.
Thank you very much, Dr. Akash, for accepting our invite and giving us a nice overview of iron deficiency anemias, along with the role of FCM in iron deficiency anemia. Thank you very much, Dr. Akash, for joining.
Thank you for the invite, Dr. Abrati. It's always it's always good to interact.
Thank you.
All right. Thank you.
So, thank you everyone for actively taking part in this academic event, and I hope everyone has learned something new today. So I'm very thankful to all our faculties who have enlightened us about the latest updates in hematology related to different topics on hematology. Then I'm very thankful to our academic partners, which includes Ross, Pfizer, Johnson & Johnson's, Dr. Reddy's, BMS, MCure, Takeda, Medgenome, GSK, Concord Biotech, and Novartis. Thank you very much for your support. And last, not the least, I'm very thankful to the Cancer Research and Statistic Foundation, who were there for organizing the event very smoothly. And thank you very much to all the delegates who have actively participated in this event. Good night, everybody.
Thank you so much, ma'am. Thank you, everyone. Technical team, please close the meeting.